So thank you. We will go ahead and get started. And good morning, everyone. I'm Mary Quay, the Associate Commissioner for Market Regulation and Professional Licensing here at the MIA. And today we will be starting off, discussing a couple of topics related to current laws and how they are affecting the markets that they address. And so the first one will be specialty drugs, and then we will be talking about a couple of anti-steering laws. Brian?
Yeah, Mary, before we get started, can I just ask a couple procedural questions? Because I know that we've had several of these meetings now, and we're coming up on when a preliminary report is going to be due. So I know we were just wondering, I know we're collecting this information from stakeholders at these meetings, but how is that going to be used? Is MIA going to be putting that together? Is there going to be some ability to have some feedback on that report? We're going to take a vote on it. Like procedurally, what's going to happen to push that out? And then is that report going to make any recommendations, or is it just going to be a kind of a listing of, hey, these are the topics we've discussed? Because there really hasn't been a whole lot of actual discussion around any of these topics. So I just wanted to kind of get a feel for what your plan was with that, and procedurally what's going to happen over the next couple of weeks to a month.
Right. I think we laid that out in our first meeting, and I do not recall the details off the top of my head. And you'll have to forgive me. I have a cold, and so I feel like I'm a lot slower than normal. But Jamie, do you want to talk about the schedule for that a moment? Or is that something you can talk about?
Sure, happy to. So the MIA is working on a draft report. As you are aware, this is an interim report, and the final report is due at the end of next year. The interim report this year will only incorporate analysis of issues that we've discussed this year. The topics discussed today, which is specialty drugs and then a review of certain laws related to PBMs, are going to be continued into 2026. So the interim report will not contain a thorough analysis of the topics from today's meeting, but the topic that we discussed last meeting, the ERISA issue, will be discussed at length in that report. The report also incorporates a summarization of feedback that's provided both at the meetings itself, as well as in written form after each meeting. So anyone who has taken the opportunity to make their voice heard, we greatly appreciate it, and that will be reflected in both the interim report this year and the final report next year. So I do want to assure that anyone that is making their voice heard and sharing their opinions, it is being conveyed in the report and will be. A draft report is going to be assembled by the agencies that are staffing this work group, so the MIA and the Department of Health. This is also in consultation with PDAB, and that report is shared with the work group itself for review before that is shared publicly. As we discussed in our first meeting when we laid out the work plan for the year, that report will be made public on October 31st, which very spooky day to do it, I suppose. And that is laid out in that public meeting that we will have on that day. We will discuss the draft report and it will be released for public consumption on that date. We will then accept public feedback and make any necessary revisions based on that public feedback before its final submission to the General Assembly in December. Like every meeting, there are 2 weeks after the meeting, after which it is released for public consumption, that people have the opportunity to give feedback on that report. So it is a very transparent process, both with work group members, but also with the public itself. Does that answer your question, Brian?
Yeah, I think so. I just we hadn't really been asked to provide anything. I didn't know what the process was going to be for that. So that is helpful. And so I guess on the 31st, we'll have the opportunity to discuss that and request any changes that we see fit before that goes public.
The 31st is when that's released to the public. So all of these work group meetings are work group meetings, but as you see from the attendee list, they are still public meetings. So that means that that is the date that will be released to the public. And so I'm hopeful that we will have time for a preview to the board members themselves before that goes out for public consumption. But either way, that is the date that it'll be going public, not just released to the board itself. Excuse me, the work group. I'm using the word board, but I'm implying the work group.
Right.
I'd like to go through our normal housekeeping matters as a preliminary issue. When it's time for public comments, we will call first on members of the work group. And then as time and technology permit, we will hear from unregistered participants who access the webinar platform. You can communicate with us through the chat function. You can also raise your hand and we will move you over to the webinar side. The MIA will continue to keep the record from this meeting open until October 22nd for additional written comments. And the video of today's meeting, as well as all written testimony submitted, will be posted on the MIA's website. And to help ensure excellent sound quality throughout the meeting, we ask that you please stay on mute unless you are speaking. And anytime before speaking, if you could restate your name and organization, that would be a great help. Okay, I see, Steve, you have comments?
Yeah, Steve Weiner from Mount Vernon Pharmacy. The last work group meeting, I'm guessing was about 5 years ago, and it was at the MIA, and it was at the MIA offices in Baltimore. And that work group meeting was a discussion between various stakeholders and the public that decided to show. And it was a back and forth discussion, trying to find compromise, trying to define things. These meetings almost seem like testimony. It almost seems like you have 2 minutes or a time to get out what you want to say. And then there doesn't appear to be any discussion. And I understand an hour is tight. It's tough. And we might want to consider making it more than that. But for these meetings to be effective, shouldn't there be some back and forth discussion as we go over the points rather than me just spitting out a minute and a half of bullet points that I think are important to what I believe in? We should be discussing it, I would think. What are your thoughts on that? And I'll put my hand down if I haven't.
I think that we want to hear from all members of the work group and have you all share your thoughts. And there are certain limitations to doing this virtually. But to the degree that we can have back and forth without people talking over each other, I think we want a robust exchange of ideas and for everyone to feel that their points are being heard. But given the limitations of the technology, sometimes it is harder to have it back and forth without compromising the ability of other people to be heard and without compromising the sound quality for everyone listening.
Thank you.
Okay, Athos, do you have any comments?
Good morning, everybody. No, Mary, I think I'm good with the introduction that you provided. Thank you, though.
Okay, and I want to welcome Delegate Cullison. And can we start with our slides, please?
Just 1 second. Thank you.
Okay.
Okay. Can you see the screen?
Yes.
If you can move to the next slide, please. Thank you. You can see it. Okay, so this lays out what we will be discussing today. I did receive some preliminary comments from representatives of pharmacists related to specialty drugs. We'll be talking about the current law there, and we have a charge to the work group to discuss. And also 2 other statutes that are in the insurance article. Next slide, please. And next slide. So the charge to the work group is to review coverage requirements for specialty drugs, including which drugs are considered specialty for purposes of formularies across carriers and across PBMs, and what these drugs have in common for purposes of developing a new definition of specialty drug. Next slide, please. Okay, insurance article section 15847. It's gone through some changes over the years. It began as a consumer protection so that consumers would have a capped copayment of no more than $150 for specialty drugs. And the current definition in that statute is on the screen now. Next slide. Others, if you want to go over this, please.
Thank you, Mary. Yes, I will. Good morning again, everybody. According to the Maryland regulations that govern the Maryland Health Choice Program, and specifically the chapter that governs the Health Choice Program's pharmacy benefits, which is COMAR 1067-0604, the term specialty drug means a prescription that is prescribed for an individual with a complex, chronic, or rare medical condition. It costs $600 or more for up to a 30-day supply. It is not typically stocked at retail pharmacies and requires a difficult or unusual process of delivery to the patient in the preparation, handling, storage, inventory, or distribution of the drug, or it requires enhanced patient education, management, or support beyond those required for traditional dispensing before or after the administration drug. And I want to emphasize that basically the Health Choice team did purposely update the managed care regulations to match the definition of the specialty drugs under insurance article, excuse me, 15847A5I, which is kind of what Mary read below. Back to you, Mary.
Thank you. Next slide, please. And this reflects the law that will take effect on January 1st, and it addresses where people can obtain specialty drugs in the commercial market. And the statute 15847 allows carriers to designate a specialty pharmacy, or it can be a pharmacy participating in the entity's provider network if the entity determines that the pharmacy meets performance standards and accepts the entity's network reimbursement rates. Next slide, please. And Athos?
Thank you, Mary. And so as it relates to the, again, Maryland Health Choice Managed Care Program, under the same regulation that I referenced below, before 1067-0604, any option of accessing pharmacy services by mail order may be implemented only at the request of the enrollee, except for when the drug is a specialty drug as defined in Section H of this regulation, which is what I mentioned in the previous slide. The regulation also does require that if an enrollee subsequently requests to use a retail pharmacy for specialty drugs, the managed care organization may not limit the enrollee to the use of a mail order pharmacy. Mary?
Thank you. And next slide. Okay, so we have talked about what our charge is and what the status quo for the regulated market and health choice are. So we are opening this for comments. Yes, Joe.
Jill,
You're
I think you are
muted.
mute. Yeah.
I apologize. Jill McCormick with the National Association of Chain Drug Stores. I submitted some information this morning around specialty. I mean, this is the issue of specialty drugs and the way that PBMs broadly designate drugs as specialty drugs, therefore taking them out of retail pharmacies and usually going to their own either affiliate pharmacy or specialty pharmacy has been very, very well documented. I'm sure you're all aware of the FTC report, the second FDA interim report that was released in January of this year. That is basically an expose on how, as states have tightened up rules or there's been more examination around spread pricing and clawbacks and other sort of PBM abuses that you've all heard of in the past, that there has been a marked shift by PBMs to cap um, to capture profit margin under the specialty piece. So I did send you that FTC report this morning, along with the summary of it. It is a huge issue. It is where the PBMs are moving now that some of the other loopholes have been tightened up. I mean, the markups are absolutely significant. They cost, and even the FTC reports on how they are costing plan sponsors billions of dollars nationally. And they are a huge profit center now for the PBMs. And what the FTC report looks at, and this goes back to one of the goals I think today is to determine, how specialty drugs can be distinguished from non-special, what we would say are non-specialty drugs, but drugs that are being designated as specialty in order to capture those profits by PBM-owned pharmacies. What the FTC found was that for these drugs that the PBMs are calling specialty, the big three PBMs affiliated pharmacies generated over 7.3 billion of dispensing revenue in excess of their estimated acquisition costs. I know Athos understands that concept. What acquisition cost is what it actually costs to buy the drug. So this is a huge issue. It is a huge cost driver in the commercial and in the Medicaid markets and in the Medicare market. And on behalf of our pharmacy members here, this is something that we feel absolutely needs to be addressed. The definition that we looked at needs to be tightened. There has to be enforcement around that definition and an easy way and a pharmacy-friendly way to report to the department under enforcement that a drug is being deemed specialty. I have looked at specialty drug lists from Maryland and other states, and oftentimes up to 20 or 30% of the drugs on those lists have a NADAC, which means they are commonly they can be, they have a NADAC because that is the acquisition cost, the national acquisition cost, which is generally assigned to drugs that can be dispensed at a retail setting versus a specialty pharmacy. So I'm just going to stop there and pause and see if anyone else wants to respond or suggest a path forward. Thanks.
Steve?
I agree, obviously, with everything Jill has said. I don't know if it's possible to back up a few slides while I'm talking. I think part of what I said before, discussion-wise, is sort of, it would help to go through things bit by bit in the legislation. What makes sense, what doesn't. This initial legislation was enacted in 2014, over 10 years ago. And that $600 limit in 2014 was high then. It's still somewhat high now, but it doesn't adjust for inflation. It doesn't adjust for what is approved on the market today. Manufacturers do not invest to put out a drug that sells for $40 and is used to treat strep throat. They just don't invest those revenues in that. And the drugs that are coming out today generally are more expensive than that $600, and they're typical drugs. These are, if we go through line by line, not stocked at retail pharmacy. Jill mentioned if it had a NADAC, it was surveyed among retail pharmacies. Not typically stocked at retail pharmacies is an opinion. I say it is. A PBM will say it isn't. That's a terrible. C should just be stricken, but it isn't. Difficult or unusual process of delivery. We've been showing patients how to use insulin for years. Injections aren't terribly hard. In terms of patient education, management, support that isn't done at a traditional pharmacy, I would suggest the Board of Pharmacy should remove my license if I am not capable of either dispensing a medication properly that is put on the market, or if I'm not capable or qualified to tell patients how to use it. Now, look at 1A, complex or chronic or rare. Acne is a complex condition. Diabetes, which is exempt from this, is complex. Blood pressure is complex. Pretty much anything, not complex, chronic. Anything other than an acute infection, one could argue, is chronic. So what this law has done, and we are all aware of it, whether we want to admit it or not, is we've given PBMs their own class of drugs, a PBM class of medication that they can decide to carve out and to limit to their own distribution center. If you go to the next slide, you talked about entity performance standards. Let's talk specifically about CVS Caremark. They're the largest pharmacy chain in the country right now, and I think they handle 8 MCO plans in Maryland, maybe 7, I'm not sure. When this legislation came out, there was discussion about URAC requirements and specialty payer requirements that they required. These requirements are very expensive. We're talking about a pharmacy, retail pharmacy, investing anywhere from $30,000 to $100,000 over a period of 3 years to get the seal of approval for specialty dispensing from an organization that's not part of the state government, a private company. What many payers like CVS Caremark have done is they have spent that 40 to 100,000 at 1 or 2 mail order locations. And they use a hub and spoke process where they mail that specialty drug out to a local CVS in the area if they haven't closed. Now, think of it from the patient's point of view. All they know is, I can't get that hepatitis C drugs from Steve, even though my friend did because he has Medicare Part D. And with Medicare Part D, Steve is capable of dispensing and counseling, but I don't. I have a commercial plan in Maryland, and I am not capable of going to Steve, but I can go to my CVS down the street, and we can use whatever words we want about it was really filled at the specialty mail order that mailed it to the CVS, but the patient knows they go to CVS and they can't go to Steve. Now, we talk about standards. Besides the URAC $30,000 to $100,000 gatekeeping requirement, the standards that are placed are a pharmacy has to answer the phone in like 30 seconds and be open 24 hours to dispense specialty meds. Have any of you called a CVS recently? You try and get someone on the phone in 30 seconds. Now, the argument is, hey, our specialty pharmacy that dispense this drug in God knows what state, probably not Maryland. Yes, might be able to get them on the phone in a few minutes, but the patient is picking these products up at a local spoked CVS. And they're, We could do right now a test. Anyone pick up the phone and call any CVS, and we'll see how long it takes to get someone on the phone. And the patients are the one that suffers. So again, you can go over each section of this, and we can talk about what's good and what's bad. We've got payers that want to save money, and I'm sure we'll hear from them at the end. I look forward to that discussion because then we can talk about the growth drivers of drug expense in this country, whether it's the typical atorvastatin and atenolol that I dispense in my pharmacy, or whether it's specialty drug. And we can talk about how much both have grown. And then we can talk about who's having a monopoly on these drugs since 2014 and how good it's worked that these cost-saving effects have occurred. So I appreciate it. I look forward to discussing each point. If anyone else has comments, maybe someone who supports all these things, it'd be nice to hear from them as well. Thank you.
Okay, thank you, Steve. And, if there are any consumer advocates who would like to talk about how consumers are protected from the high cost sharing by the statute and the effect of changing the definition of specialty drugs on the patients who otherwise might have very high cost sharing, I'd love to hear that point of view as well. So, Heather?
Thank you, Mary, and thanks everybody for the opportunity to weigh in here. I'm hearing a lot of discussion about dispensing channel and access to medication for the providers who would like to dispense it. And when I look at the objective of our task here as work group members is to also give consideration to the affordability of these medications, the safety of them, and patient compliance. And so it stands out to me that we should also be giving fair consideration to both plan sponsors and patient impact. And it's frankly plan sponsor decisions that impact what is a specialty drug for their plan participants. Ultimately, the state of Maryland may choose to have a specialty drug list or not. Local governments or counties here within the state that affect Marylanders may choose to have a specialty drug tier or not. And while PBMs do serve a very important role in helping educate them and their sophisticated brokers and advisors as to what new drugs are coming to market, which happen all the time, and the cost impact and the side effects of all of those medications, ultimately it is their criteria within the confines of the Maryland law, of course, to determine what drugs they want to cover as specialty drugs. There are, of course, plenty of non-PBM owned specialty pharmacies that exist within the state. Those plan sponsors are making important decisions about what's covered, at what degree, and where to procure them. I think one very important thing that this work group needs to keep in mind is that anything that is not considered a specialty drug, if we make changes to the criteria, excuse me, changes to the criteria, and I understand that that may be something we're tasked with, I'll note here that the criteria that was outlined in that law, I was part of that process and crafting that law many years ago, was a very long deliberative consideration process about all of the aspects of what makes specialty drugs, that it's not just about cost, that it's also about what complex or chronic condition is being treated by that medication, the special handling requirements that might be required for it, administration requirements that might be required for it, storage, all of those things were part of our discussion when we crafted that definition. And today, as we reconsider that definition, if we are discussing taking things off of that list, what's important to note here is anything not on the list is also not going to be protected by the specialty drug copay cap for patients. So there's an affordability for patients, for Marylanders, that really needs to be considered as we're making or considering changes to what should or should not be a specialty drug. Lastly, I'll just respond to some of the comments. I think it's interesting now that we're developing the access part of specialty drug conversation, whether those drugs should be procured through mail order pharmacies, through retail pharmacies, through retail specialty pharmacies. Ultimately, again, this is a plan sponsor decision. I'll note that the sort of the design of retail and how consumers shop for things has evolved dramatically, even since that law was written many years ago, right? We've had COVID since then. In the last 5 years, consumer sentiment on how they shop for things like clothing or furniture and drugs is evolving. PBM mail order pharmacies are not the only mail order pharmacies that exist, and people do like the convenience of that. But that's not by PBM design. That's just the nature of how consumers shop for things these days. And so while that is driven by pharmacy economics and in some part by COVID and just changing consumer sentiment, we need to be very mindful of allowing as much flexibility for the patients that are affected by these drugs. Patients that are taking specialty drugs have very serious illnesses in some instances and very much benefit from having the choice to get those medications shipped to them. So just something for us to keep in mind as we continue the conversation. I want to make sure we're, remembering that these are plan sponsor choices and that patients are protected by this law in many ways as a result. Thank you.
Thank you. And I'm keeping an eye on time. It is 11 and we do have the other statutes to get to. But Brian?
Yeah, I'll be quick. I mean, as someone who was in those discussions over 10 years ago now about this definition, it was a very much a horse-traded definition of what a specialty drug should be, based around this $150 copay limit. And at that time, the influence that CareFirst had over that process in instituting a $150 copay limit made a bunch of this other stuff happen that really is a garbage definition of a specialty drug. So I know I understand why that's important, but what we've seen since then is the out-of-pocket expense for insurance, not just copays, deductibles and actual costs to the consumers in Maryland have skyrocketed. This $150 copay cap is a drop in the bucket compared to the out-of-pocket costs for Marylanders when it comes to insurance and prescription drug coverage. So while it's great for the PBM to say, we're going to hold this cap, and if you take these drugs off the list, it's just going to cause patients to pay more, they're already paying more. They've got other ways around this $150 copay cap that have cost Marylanders a lot more money than $150 over the time period since this has been put into place. So, insurance companies, PBMs, they're going to get their money one way or another, and that's essentially just one way that they can, one olive branch that has been given to patients in this process was this $150 copay cap. I wish we would have treated it as a separate issue back then. The state could have put a $150 copay cap on prescription drugs if they wanted to and specified what it was, and they could have defined specialty however they wanted. I really wish those two issues hadn't become conflated like they did.
Thank you. Aaliyah?
Hi, Aaliyah Horton with the Maryland Pharmacists Association. I did just want to bring to the group's attention that I did submit a report that was conducted by my colleagues in Washington State of the Washington Pharmacists Association, looking at the cost experiences of commercial plan sponsors and the reimbursement experiences of community pharmacies. And within the context of this discussion, I just wanted to highlight two key points from that study. One was that PBM affiliated mail order pharmacies had prescription markups that were more than 3 times higher than the markups at retail pharmacies. And they did look at a subset of claims that were comprised mostly of specialty drugs, and plan sponsors were charged more than $1,000 in markups per prescription at PBM affiliated mail order pharmacies, despite retail pharmacies typically filling those medicines at a loss. So when we talk about, plan design and the plan sponsors making these decisions, I just wanted to raise the issue that with the opaqueness of this PBM process, that plans are spending more going through the way this is set up now versus having more openness working with community pharmacies. Thank you.
Thank you. Kim?
Thank you, Associate Commissioner Quay. Kimberly Robinson for Care First Blue Cross Blue Shield. I too was there when this law was being drafted a little over 10 years ago, and it was a hard fought law to create. I think that the cost sharing that is capped in this law is really significant for Marylanders. There are lots of states who do have laws and other things that speak to specialty drugs. When I Googled it, the first thing that came up was actually from the Iowa Department of Insurance, where they have a definition of specialty drugs that is almost identical to the definition that's being used here in this statute. It is not an uncommon definition of what a specialty drug is to talk about a drug that treats a complex or rare condition that has these other caveats that are present in the Maryland law. And this is, in fact, an insurance law at its core, right? It's in the insurance article, and it's in a space where it's actually speaking to carriers about how we are to cover, where we are to include them in our networks. And part of that trade-off is, in fact, that controlled distribution in exchange for the cap on the cost share and the copay. To be clear, I can say, having been there on the carrier side, although not wearing a Care First hat, this was not a law that was loved by insurers at the time, because drugs are really expensive. They were expensive 10 years ago. They are astronomically more expensive today. That has an impact for the members who need to obtain them. It has an impact for the plans who are looking to cover them. The more cost that we shift into the plan, it still shows up. As one of the former actuaries at the MIA used to describe it, costs are like one of those balloons you make, balloon animals out of, that hot dog balloon, and how much air you need in it is how much cost you need to cover a plan. It doesn't matter where you put your hand. One side is cost share, one side is premium. It's all the same amount of air. And in this case, it was saving the consumer from being the one to carry that cost. To impact that networking, that helps to allow us to partner with those who are managing our pharmacy benefits to control those costs, has an implication as well. If we build more costs in the system, we create more costs for patients. And so I don't want us to lose sight of the fact that ultimately this is a law that is, as Ms. Cascone said, not about insurers or pharmacies, frankly. It is about patients, both in what they're getting to access in terms of their coverage, ensuring they do in fact have access to what they need, but also knowing that affordability is the first step to accessibility. Because if they cannot pay their premium or for their copays, they will not get those benefits. Has to be part of this conversation.
Thank you. Beverly.
Good morning. I represent Queen Anne's County government. We have a self-insured health plan that includes our pharmacy. And years past, our pharmacy spend represented maybe 5% of our total costs. It's up to maybe around 25% now. And a lot of that is driven by specialty drugs. And we do have a category for specialty drugs. And I wanted to validate that. I think Heather mentioned it earlier. And we do have a unique program for our members for specialty drugs. So those that sign up for that do get a reduced cost for their specialty medications. So that is something that we do implement. So that does have a direct impact on our members. And I also do think last time we talked a lot about transparency. So I think that is critical in all these discussions. It is helpful for us when we're dealing with our PBM to know what all the costs are so that we negotiate those prices. We know what we're paying for on our end so that ultimately it helps us when what we set prices for our members. So I think that is critical in all these discussions as well. Thank you.
Thank you. And can we move on to the next slides and we can resume discussion at the end? Okay, next slide, please. Okay, we were also charged with reviewing provisions of state law regarding PBMs, specialty pharmacies, and anti-steering, including section 151611.1 of the insurance article and section 151612 of the insurance article, and looking at those related to reimbursement and pharmacy costs in the insured market. Next slide, please. Okay, so here is 151611.1, which will take effect January 1st. And this applies to PBMs that provide PBM services on behalf of a carrier. So this is one that does not apply to ERISA plans. And a PBM may not require that a beneficiary use a specific pharmacy or entity to fill a prescription. If the PBM has an ownership interest in the pharmacy, or the pharmacy has an ownership interest in the PBM or is a corporate affiliate. And it does state that a PBM may require a beneficiary to use a specific pharmacy or entity for a specialty drug. Next slide, please. And again, this takes effect January 1st, 2026. And it is, again, a PBM that provides PBM services on behalf of a carrier. And it does not apply to reimbursement for specialty drugs, except as in 15847.2. Mail order drugs or for a chain pharmacy with more than 15 stores. And it says that the pharmacy cannot be reimbursed in an amount less than the PBM reimburses itself or an affiliate for providing the same product or service. So, next slide, please. And we are again opening it for discussion. Work group members first. Steve?
Okay, well, two things regarding this new section. If it only applies to ERISA plans and it appears that everything in the world's ERISA, I would recommend the committee not waste too much time on this section. It's going to be futile, to be quite honest with you. It excludes specialty drugs, which is, as I think Beverly mentioned, that's the bulk of the growth expense of what payers are paying. So this exempts specialty and it exempts ERISA. Let's focus our finite amount of time on more important things. There was a definition of specialty drugs in the health choice arena, and this question is directed more to the Maryland Department of Health representatives. With pro DUR, the state of Maryland gets to see the MCO health choice claims. Joe Fine, who developed that many years ago, one of the wisest things he did. There shouldn't be any surprises in MCO and health choice claims because the state should be able to see everything. The FTC study and a lot of the issues that retail pharmacy brings up has to deal with this monopolistic behavior where the PBM has restricted the dispensing of these medicines to their own pharmacies. And there's an allegation that they are enriching themselves with that privilege. With the health choice program and MCO claims, it doesn't seem to me like the programming would be hard where you say, okay, if a claim reimburses at NADAC plus 1067, and if it reimburses more than 5 times that, flag it, send it to a report, and let's look at it. And we already know that the state doesn't care when MCOs reimburse at NADAC minus 99%. I'm not asking that. That has to do with my atenolol. But when an MCO restricts the drug to their own vertically integrated dispenser, we should be looking at those claims and seeing if they're reimbursing 5 times or more the amount of what the state would pay. And we have that data. We have the ability to do it. We should do it. And if we do it and we see it's happening, what is the state of Maryland's recourse for doing that? So if you guys could comment on that, I'd appreciate it.
So Steve, just so that I better understand your question here, and I'm going to focus on two things. Number one, you keep saying that the PBMs and the MCOs are are mandating their members to go to their specialty drug pharmacies, I should say. The comment that I read earlier does explicitly state that it's the choice of the member.
So with Hep C drugs, okay, every MCO managed by CVS Caremark, and I apologize, it's either 7 or 8 of our MCOs are managed by CVS Caremark. They restrict under health choice, they restrict those drugs to their own vertically integrated pharmacies. Now, what you read says they can't restrict to mail order, and they wordsmith that. They don't. They restrict it to their specialty pharmacy, not their mail order pharmacy. And they locked out every other retail pharmacy in the state except the ones that they own. And their mail order pharmacy mails that to their local CVS. So they're not restricting the mail order, but they're restricting to their own specialty network. And again, Hep C is one thing. I mean, you should be looking, you know what the state pays. So what are the MCOs reimbursing their own pharmacies for that? We should be looking at that. But the real cream is when that Gleevec goes generic and they've convinced everyone to send it to their own pharmacies. And now generic Gleevec, which costs $30, is being reimbursed at thousands. And I would remind everyone on this committee the reimbursement rates that we'll talk about later that pharmacists have requested under the Health Choice program are far less than Mark Cuban's cost plus drug. We are the cheapest state in town as far as that goes. But my question was things like MCO claim, like Hep C, like Gleevec, generic specialty meds that are being restricted under the MCO program, whether you're aware of it or not, they are. Health Choice should be looking at what they are paying. The state of Maryland should be looking at what they are paying for those claims. And you have it under Pro DUR. And that should be compared versus what the state would have paid if it wasn't an MCO claim. And that's low-hanging fruit. Now the question is, once you find out if they're reimbursing themselves tremendously more than what is reasonable, do you have any recourse? I suspect you don't under the legislation. But the first thing is to open our eyes. Let's see what's going on. And then once we know what's going on, you can say, Steve, you're a lunatic. You're crazy. You're taking too much time at these meetings and you don't know what you're talking about. Stop asking questions. Or you can say, you know what? Generic Gleevec, they're paying themselves $2,000 for a drug that's got a $20 NADAC that's on Cuban's cost plus for $30. We need to look at this. And the response has been, there's always a few outliers. Well, I'll tell you, a few outliers make a whole lot of money versus under reimbursing every community pharmacy below their cost in the state of Maryland. Those few outliers really they make a big difference. And again, other states don't have this. Because of Pro DUR, the health department sees every claim. And there was a study a few years ago where they looked at my claims. Not only do they see the drugs, the Pro DUR claims you see the amount being paid to the pharmacy. And whether we're doing anything with that data, I don't know. But that's part of the brainstorming of something like this to try and save the state of Maryland money and also the commercial payers.
And
So,
patients.
and patients, of course. The patients, I apologize, since the law was enacted, every manufacturer has a copay assistance program. So whether they pay 150, 250, 3, 500, the manufacturer's kicking in unless the PBM's stealing the copay assistance money. But that's a whole nother discussion. So
And the co-payment doesn't apply to Medicaid because Medicaid has $1 or $3 copays, right? Or as Steve
right.
should know, if the patient says I cannot afford it, still have to give it to the patient. So the
Correct,
copay.
but all this goes to what the state is paying. What are the rates you're paying to the MCOs? While those could be lower and you could control them more, and that actually the cost of a drug could actually go down, if these issues are fixed.
I'm not going to disagree with you, Jill. I was just making a
or
point
looked
that
at.
the patient doesn't get affected under Medicaid if the drug is $1,000 or $30. That's what I was saying. Because
Agreed.
their copay will be the same. And they actually, if they're children, if they are pregnant women, a whole bunch of other categories of patients don't even have to pay a copay. They are exempted.
Correct.
I will
As it
take
should be.
your inquiry, Steve, back. I'm not at the position to make that decision. I will have to discuss it with the a whole bunch of different folks here, and see if we're able to do what you suggested. But I also want to reemphasize: if you do know that they have, that the patients are mandated to go through that, you are more than welcome to tell the patient they don't have to take the
So,
drug from specialty pharmacy. All they have to do is just reach out to their PBM and say, I want to get it from a retail pharmacy, brick and mortar pharmacy at Mount Vernon or wherever, right? The patient has that option.
so they're not restricted to mail order, but you're saying
Even
they can't be
specialty pharmacies,
they can't be restricted to another local because that's not what we're getting. I mean, we're having patients at Healthcare for the Homeless with access problems to specialty drugs. And I'll
so
get you
can we
specific
go to slide
examples.
8 very quickly, Mary, or whoever is managing the slides?
Yep. Craig? Back more.
Yep. I'll see the slide number, but keep going back, please. More. Okay. And now go down. I think you went back too far. Good. I think this is 6, 7. Keep going. One more. There you go. Under I, if an enrollee subsequently requests to use a retail pharmacy for specialty drugs, the MCO may not limit the enrollee to use of the mail order pharmacy.
So they're not limiting the mail order. They're saying you can use a retail pharmacy as long as it's CVS.
They cannot limit that either, right?
They
It's
can.
I'll get you
Okay, can you give me
examples.
some, by all means, if
Absolutely.
you have my email, send me some examples.
Okay.
I'll
You
look
got
into that as well. Thank you.
Okay, I want to give attendees a chance to volunteer to talk. If there is anyone in the attendees who would like to be moved over to say something, please raise your hand. Okay, not seeing anyone. Anyone else on the work group have anything to say?
Yes.
Okay.
I just want to highly recommend. I mean, all of the issues that pharmacy and others have brought, that we have brought up today are very easily backed up. There have been studies after study on specialty steering, on, PBM abuses. Other states have done deep dives. There are third-party experts out there. I mean, I'm talking about the FTC report, which was widely publicized and widely read. It just seems to me that what we're doing here, and again, I do sympathize. There's not a lot of time. These are complicated issues, but the reason why I think the legislature wanted this to go to a work group was to do a deep dive. And it also in the legislature talks about bringing in third-party experts. We can continue to meet like this, and we'll go back and forth between the opposition, proponents and opposition. But in order to really get to the meat of this, we really need to bring in some third-party experts to start at a high level, and then come down to brass tacks on these issues and show you, not show you, but show everyone, where the evidence is to back up, what we are saying today. All of our goal here, if I could speak on behalf of pharmacy, is to improve access, lower costs, not to cause plan sponsors any more money. And in order to really do a deep dive on this complicated issue, I think we really need to bring in some plan sponsors. And just what Steve and Athos were talking about earlier, about looking at what a NADAC is, and looking at whether or not Maryland is overpaying, let's say in the managed care system, for these drugs that are being steered and overcharged. I mean, there is data online. There is a heat map online that is easily referenced, that I will be happy to share to send you the link to. But I really highly advise that we start bringing in some third-party experts and look at the evidence and get the data that we need, because the bigger problem here is always, as Aaliyah and others have referred to, opaqueness and non-transparency. PBMs are controlling the cost of the drugs, and they're controlling where they're getting filled. Ultimately, that goes to access, and it goes to patient access. And it also goes to the viability of pharmacies. If pharmacies are not paid a reasonable amount to purchase and dispense a drug, there won't be any access to a debate about. Thank you.
Okay, thank you. Delegate Collison, please.
Thank you very much, Mary. And I want to thank the work group and the public that have been attending today on this really important meeting. As I was listening to the comments from all sides of the issue on the specialty drugs, I think as you think about the interim report, I'd like to propose that the issue around specialty drugs can be encapsulated in one, improving the definition. The definition that was done in 2014 is clearly not workable in today's pharmaceutical market. It just, in that amount of time, the cost of pharmaceuticals have tripled, and the payers are paying 33% of every premium dollar for drugs. That wasn't true in 2014. It was closer to 17 and 18%. So we're in a different market right now, number one. So definition has to be worked on, that meets these times and these facts, the facts that you just heard. In some plans, the drug is classified as a specialty, and in another plan, it's not. To me, it either is or it isn't. I think the other thing we need to consider is who can dispense it. Once there is a clear definition of it, who can dispense that drug? What are the requirements? And I have to tell you, I take specialty drugs. I get them from a mail order that sends them to my CVS. So, and I inject myself. And then how to protect consumers from cost. I think this is an issue that Maryland is working on in several different venues, and that we can figure out how to manage that. I know that was a primary concern in the initial discussion on specialty drugs in 2014. But as I said, we're in a different place. There are many instances, I think, where people are paying more than $150 copay on a drug that's not specialty. So I could be wrong, but I suspect, I'm standing at pharmacy counters and hearing what people in front of me are paying. So, I think for me, those are the three elements that in your report, I hope will be reflected, that we have to to really address going forward on this issue. Thank you for the time and for the work that you're doing on this.
And thank you for that input. It's very helpful. Kim, we're at 11:30, but I will give you a very brief opportunity to speak.
Thank you, Associate Commissioner Quay. I'll just do this instead. So let me echo what Delegate Collison said just about the complexity of this issue, that there are a lot of moving pieces to this, and I appreciate the work that the MIA and the Department of Health are doing to address it. I would encourage that since we have the opportunity to do an interim report followed by final report, that there be an investment of time to really understand this issue. At the end of the day, as a plan who is looking to provide the best access to care at the most affordable price point so that people can get what they need, finding that balance is really important in terms of understanding what we're talking about when we mean specialty drug and where people are accessing those drugs, beyond, I think, some of the things that have been said today and some of the rhetoric that one might see online around this issue. And so I'll just leave it with looking forward to continue to talk about this issue and work through it over the course of the next year as we approach a final report.
Okay, thank you. And we appreciate everyone's participation. It's been a lively discussion. And the email address for written comments is on the slide on the screen. We will be accepting those for the next 2 weeks. So thank you, everyone.
Thank you.
Bye.
Thank you.